types of spinal pain, approach to diagnosis and intervention management. First of all, we are clinicians. Before we are not photographers, we are clinicians, we are an intervention radiologist, diagnostic radiologists, musculoskeletal radiologists who are interested in diagnostic radiology or intervention radiology. At first, we are clinicians. We are not a photographer only. So, when we are talking about the pathology of pain, we are talking about the spinal pain, musculoskeletal pain, cancer pain, and the cranial pain. The spinal pain may be radicular, discogenic, facetogenic, sacroiliac, vertebral fracture or paravertebral masses, muscles of the back, neural canal stenosis, paravertebral masses, failed back syndrome, and arthritic pain. The musculoskeletal pain may be post-traumatic and post-operative pain also, and maybe also ischemic pain, a malignant pain, and benign lesions like we are talking in the first lectures about benign osteodysteoma and the osteolytic lesions. The main types of spinal pain may be classified according to the location, the complaint, may be radicular, discogenic, facetogenic, sacroiliac, muscular, vertebrogenic, neural canal stenosis, instability, and paravertebral masses. The clinical approach by history taking and physical examination and by imaging, we all know this, and also by nerve conduction velocity, and also studies, and also by diagnostic injections, which is considered one of the clinical diagnostic tools. The history and physical examination are important. We are doing this, taking history of the patient by ourselves, and we are making our physical examination, not relying on the physical examination made by neurologists or rheumatologists or neurosurgeons. We are doing our physical examination by ourselves. The radicular pain is the most common type of pain. All of population, about 80% to 90% population may experience radicular pain in one time of their life. So it may be caused by nerve irritation or compression, by radiating pain, and it's sharp shooting and burning like electrical shock like, and the location, if the cervical in the lumbar is different. So in the lumbar pain, it's in the lower back, buttock, leg, and the foot, and it's called sciatica. So the differential diagnosis of low back pain is expansive, but for clinical purposes often divided into mechanical and non-mechanical types. It's another classification system for low back pain, and with symptomatic complaints of a unilateral pain may be referred to lower extremity. So the radicular pain has many causes, and this is the simple photo from one of our cases by a typical case, failed back syndrome with fixation and with the imaging by radiofrequency needle by nerve roots, and this is transpedicular fixation done, and this is the needles of radiofrequency positioned in this place. This is a typical case. This is normal case in our practice, and also we can do this by CT guided approach, and also these are different cases for spinal pain, like facetogenic injection and knee injection, and this is 3D image for CT guided radiofrequency for spinal pain. And facetogenic pain is the second type of pain, and is considered as a pain which is worsening by extension, rotation, and lateral bending of the spine, and also by prolonged standing or walking, and it's improved by flexion or sitting. This is the main type of facetogenic pain, the main complaint, and this is one of typical cases of CT-guided radiotomy for facet joint pain. The discogenic pain it's commonly misunderstood and is commonly missed, and is centralized or slightly lateralized to the spine. Nature, deep aching or throbbing pain, and by aggravated and worsened by prolonged sitting and bending forward or axial loading, and also improved with lying down. By the treatment of discogenic pain, we can do three techniques: annuloplasty, nucleoplasty, and annuloplasty. So, annuloplasty, treating the annulus, the annular pain, the pain originating from the nerve ending in the annulus fibrosis, by doing acuplasty or intradiscal electrothermotherapy. The nucleoplasty, do you do nucleus pulposus herniation or PULSH? Maybe by coblation therapy and contained disc herniation, or percutaneous discectomy or herniectomy. And the third technique is annulonucleoplasty, is called disc fix procedure. These are general inclusion criteria for minimally invasive treatment. We have a lot of inclusion criteria for minimal invasive treatment for the discogenic pain, but we should discuss the first intradiscal by aculoplasty, when we are making our needle in both sides of the vertebra, like this. This is the video. And the marking by the needle holder, making a marking for the spine, for the position of the needle inside, like this. Two needles are directed here, two sides of the annulus fibrosus here, like in this and in this. These two needles are parallel to each other to make radio frequency by bipolar radio frequency to treat the annular pain. This is called annuloplasty. And this is another technique. I don't do this technique. I don't perform this intradiscal electrothermotherapy, making like this is a wire, making a thermal effect to all annulus fibrosis to treat the pain. The second or third technique is the nucleoplasty, by making an intradiscal inside the nucleus pulposus, making a coblation therapy for L4, L5 intervertebral disc for a discogenic pain to evaporate the disc nucleus pulposus and help in hernia shrinkage by the effect of heat power of shrinkage. And this is one of our cases by doing a coblation therapy by L4-5 intervertebral disc. This is the third technique is percutaneous discectomy. These are cases from our friend Dr. Nicola from Nice, by him making the device or herniotome inside the interlaminar space and then making hydrodissection to the neural canal and making discectomy to this herniated disc. And this is done CT guided better, and it looks like the interlaminar endoscopic technique for herniectomy for the spine performed by some neurosurgeons. And the third technique, which is herniectomy, which is called disc fix technique, it's a combination of annuloplasty and discectomy and radiofrequency ablation to the annulus fibrosus and to the disc inside material. And this technique, this is a video of the technique. We're making forceps grabbing for this herniated material here, making some extrusion to some disc material anterior, just anterior to the inflamed area, and then making our radio frequency like in this technique, in this procedure, one of our cases. And you can see in the video here, we can making, you can see forceps grabbing. And after that, by the same channel, we are doing radio frequency to make a sealing. And this is the fragments of the disc here. And this is the intradiscal radio frequency to make a sealing for the cutted area. The vertebrogenic pain, it's commonly missed, and it may be benign or malignant vertebrogenic pain. It looks like discogenic pain, but the discogenic pain is worsened by leaning forward, and all are the same. But the vertebrogenic pain radically may be due to end-ablated changes in grade 1 or grade 2 end-ablated changes, or maybe due to fracture of the vertebrae. So the basivertebral nerve block, we are doing basivertebral nerve ablation, maybe a unipedicular or bipedicular approach like this, and making this ablation for the basivertebral nerve to kill the basivertebral nerve inside the vertebral body, to making pain relief of this vertebrogenic pain. It's a promising technique. And the percutaneous vertebroplasty we are performing to the L5, L4, L3, the common areas. And this is one of our cases. It has a malignant lesions inside many vertebral bodies, and we are doing ablation, and we doing also cementation to multiple levels in the same session. For this case, it has a malignant case, and after that pain may be free in some cases. This is one of case reports we are doing it. She had an unexplained vertebral fracture not treated by endocrinologist or orthopedic surgeon, and with the shortening of the stature by 10 centimeters. We decided to do 10-level vertebroplasty in the same session. You can see 5 vertebral lumbar vertebrae and 5 dorsal vertebrae. We did vertebroplasty in the same session in 70 minutes. We should be concerned about the inevitable escape of vertebral of the cement inside the lung, but we shouldn't exceed about 18 to 25 milliliter of injected semen. The percutaneous fixation we almostly done in cases of vertebral plan in malignant cases, or in osteoporotic cases we're doing it, and we're doing it also assisted by vertebroplasty, making by cannulated screw, and like in this case with the vertebral plan here, we decided to do cannulated screw percutaneous fixation with injecting semen inside this and inside this level. And this is the description with me and my colleague neurosurgeon by this procedure. We are posted in, we did a lot of cases like this. And also there's another case with mass effect like this, but the patient has short life expectancy, and we decided to make percutaneous fixation to relieve pain because he didn't respond on medications. Also, the neurosurgeon refused to do any decompressive study for him, and he did this as a palliative for a metastatic cancer liver. And this is another patient with sacroplasty in the same session. We did a sacroplasty in the same session. The patient has L1, the patient has S1 vertebral metastatic lesion, and we did it like by needle guidance protocol in the angiosuite machine, and also making 2 needle fixation with the 3rd needle for vertebroplasty or for sacroplasty. And fortunately the patient is now free of pain. After 1 week the patient became free of pain, and also stopped making taking any tramadol, any morphia derivative medication after this. And we can see the after procedure cone beam CT. This is the injection of the semen inside the vertebrae. We can wait to see the CT after image. Concentrated of the semen, no escape to posterior canal. And this is a cone beam CT with good concentration and good positioning of the needle after that. For post-operative pain, you usually do adhesive lysis by Rax catheter, injecting hyaluronidase by sacral hiatus, and the response was great in many patients, and making also more advancement of the Rax catheter inside this. And this is also another case of sacroiliac joint injection by sacroiliac joint pain. We do it by fluoroscopic and CT guided also, and this is our publication in Q1 journal about comparative study between fluoroscopic sacroiliac injection and the CT guided. And it is the first case of cryoneurolysis in Egypt we did this week, and you can see this cryoneurolysis for sacroiliac. This is by catheter, and you can see the ice ball disappeared by thawing effect. And this is, you can see also, this is frozen ice, about minus 80 degree CO2. We use the CO2, and by this machine the patient has pain-free. And we did in the same day some cases also for knee cryoneurolysis. They are the first cases in Egypt recorded. Sacroiliac joint fixation, we're doing it also in benign cases with severe sacroiliac pain. So we are doing sacroiliac joint injection, CT guided, fluoroscopic guided, sacroiliac joint cryoneurolysis, and sacroiliac joint fixation, in some cases resistant to treatment by injection or ablation. And this is the CT finding. You can see the good position of the needles by sacroiliac joint fixation. For neoplastic pain, we are doing maybe vertebroplasty like this and fixation, also bone metastasis, cementoplasty, and ablation of the bone metastasis and bone embolization. This is a case of osteodystioma in in 6 dorsal vertebral level. We did also in this case, the neurosurgeons refused to do this, and I decided to make radiofrequency ablation for osteodystioma in this difficult place, 1 milliliter from the heart and from the lung, and the patient is now doing well. And also by paravertebral metastasis, we are doing palliative embolization to treat pain and to decrease the release of inflammatory mediator. We know the embolization, like we were talking in the next lectures about the embolization, can relieve pain from many places, like in the knee, in the shoulder, and also in painful metastatic lesion like TAMI or transarterial microembolization technique. And the embolization here for sacral metastatic lesion, and embolization for a paravertebral lesion. This is a lesion, the patient has a sacral metastatic lesion. After only 2 days, the patient was free from pain, and this is not explained. The pain after embolization was decreased dramatically in this patient. In conclusion, the interventional radiology can give a good alternative option for many conditions in patients suffering from severe and intractable pain. Also, interventional radiology is the only treatment for many conditions of intractable chronic pain, like in patients with failed back syndrome. Interventional radiology is a good option for many patients to avoid surgery, like in most of spinal pain syndromes, like facetogen or sacroiliac pain. Thank you.
Thank you, Dr. Ahmed, for this comprehensive presentation. Very interesting case.